Hello, I am Susana Castro-Chavira. I will present to you this talk named Longitudinal Neurodevelopment in Infants with Prenatal and Perinatal Risk Factors for Brain Damage Treated with Katona's Neurohabilitation Method. I have not any disclosures. I will be talking about, first of all, prenatal and perinatal risk factors for brain damage, and particularly about preterm birth. And then I will talk about the brain damage in newborns produced as a consequence of all these preterm risk factors. After that, well, I will talk a little about development, plasticity, and recovery, and their implications for the neurohabilitation method, the Katona's neurohabilitation method. And finally, I will talk about the brain structural changes and neurodevelopmental outcomes after Katona's neurohabilitation therapy. This work was performed with help of 36 participants with prenatal and perinatal risk factors for brain damage who were treated with Katona's neurohabilitation method. We used anatomical brain magnetic resonance images of these subjects at 3 age ranges. First, between 2 and 3 months old, then at approximately 1 year old, and finally between 2 and 3 years old. And we also collected the neurodevelopmental outcomes using as measured by MDI and PDI Bayley scale scores at 3 years of age. The objectives of this work were first to evidence brain damage in infants with prenatal and perinatal risk factors, then to evaluate longitudinal changes in corpus callosum and lateral ventricles, and finally to assess the neurodevelopmental outcomes in these children. So first, let's talk about prenatal and perinatal risk factors of brain damage. In fact, these three types of risk factors, as you can see, I used a dashed line to separate them because many of the prenatal factors also become or have a consequence in the perinatal period, and finally they affect as well the postnatal results. Also, according to its origin, these risk factors can be maternal, placental, or from the individual, either fetal or infant. But also, as you can see, many maternal factors become or affect placental factors. And finally, these as well interact with the individual, for example, with the fetus characteristics. And there are many factors. I only represented some of them, the most important, and particularly the ones that we found in our sample. So as you can see, for example, in the maternal prenatal risk factors, we have demographic and lifestyle factors and fertility treatments if they were used. Also medical disorders that the mother could have, from metabolic to hypertensive or any other. Also her pregnancy history, if she had short periods of time between pregnancies, or if she had preterm birth or preterm labor before. All those affect, of course, also if she presents preeclampsia or eclampsia, that as you can see, it's more to the right because there's an interaction with placenta and with some pregnancy complications for them to present. And one thing that I would like you to see or you to notice is that in these three categories we have infection from maternal to placental and individual. And infection also can be not only prenatal but also perinatal. and postnatal. You can have sepsis here and affecting the fetal the life of this new infant. And of course, all of these factors interact and may produce severe consequences. Specifically in our sample, the most prevalent risk factor was exactly maternal infection in around 56% of the infant. Oxygen supplied, they required oxygen, around 40% of our sample. Also, they presented with sepsis in more than 35% of the cases. Asphyxia was also a very had a high incidence of more than 30%. Apgar less than 7. Seizures, metabolic disorders, fetal distress, previous abortions, toxemia, meconium ingestion, and undernutrition with a very low rate. Well, a lower rate. It's of course not desirable to have this. Particularly preterm birth, that was on purpose not on this on the previous chart, is a very important factor. It is the first cause of mortality and morbidity nowadays still, and its rate is between 5 and 15%, not only in low resource countries, but also it still prevails in high resource countries. Preterm birth, of course, has this dyad with preterm labor, and then preterm parturition can be induced by infection, cervical pathology, uterine overdistension, progesterone deficiency, vascular alterations, maternal and fetal stress, allograft reaction, or allergic phenomena, only to mention some of them. All of these causal or all of these causes of preterm labor can only have or may have some synergistic effect with the other risk factors, or like fetal or individual risk factors, as we were seeing. And well, according to how long the gestation was lasted before this birth, there's a classification of the World Health Organization and March of Dimes and other associations that considers that children with infants with less than 28 weeks of gestation are extremely preterm. From 28 to 31 weeks of gestation, they are considered very preterm. From 32 and 33 weeks of gestation are moderate preterm, and 34 to 36 weeks of gestation, they are late preterm. So a pregnancy of 37 weeks or more is considered as a term, a baby, the baby was born term. In the case of our sample, most of our infants were born at term, but they still had other risk factors. So this was not the only risk factor, but in the rest of the sample, it was a very important part. We had 19% who were born late preterm, 3% moderately preterm, 6% very preterm, and 3% extremely preterm. And well, as we were mentioning, then all these risk factors are a problem because they may produce, or they are related to brain damage in these newborns. Generally, survivors of prematurity face a lifetime of neurologic impairment. It can be just some subtle neurologic impairment, but it can also be a debilitating neurologic impairment. Extremely and very preterm infants have reduced overall brain frontotemporal and hippocampal volumes. And in the case of moderate to late preterm infants, also overall brain reduction in volume has found, and reductions in the volume of corpus callosum, deep gray matter, and cerebellum. Also in these moderate to late preterm infants, reduced myelination in the posterior limb of the internal capsule, and immature gyral pattern have been found at term equivalent age. And preterm infants showed slower maturation in the body of the corpus callosum, inferior longitudinal fasciculus, and left dorsal visual stream. So all of these are structural changes that may occur due to this brain damage. In the case of our sample, we found these clinical findings. 14% had normal or apparently normal MRI images, MR images. More than around 46% presented dilated lateral ventricles. More than 20% cystic encephalomalacia. More than 10% cystic lesions and myelination delay. And 9% thinning of corpus callosum and germinal matrix hemorrhage, and finally, not so big but important amount, like around 6%, presented intraventricular hemorrhage. Let's remember that all these factors may accumulate or have a synergistic effect. So it's not only the preterm birth, but it's also the comorbidities that might have this synergistic effect and produce in the end some different consequences or sequelae. Particularly neurophysiological damage in newborns as a consequence of prenatal and perinatal risk factors might be, for example, the retinopathy of prematurity, which creates or might have as a consequence important or severe visual impairment. Also, the visual dorsal stream, even if there is no retinopathy of prematurity, the visual dorsal stream is more vulnerable to prematurity, and there have been some difficulties in the processing of movement, even if the individual didn't present retinopathy of prematurity. Also, these periods of more than 5 days in the intensive care unit, in the neonatal intensive care unit, represent an important risk factor for hearing loss. And this hearing loss may be produced because the sounds, there are a lot of sounds that have very high volume, and then they can be a problem. And of course, this hearing loss might in turn affect language acquisition, not only comprehension but also production. Also, somatosensory receptive pathways are not completely mature, so those for noxious and benign stimuli may overlap, and this may hinder discrimination between some, for example, pain signal and benign signal, and this produces later big problems in this area. Preterm infants are also more likely to demonstrate sensory processing disorder. In the case of motor disability or motor problems, one important problem is cerebral palsy. And we know that infants with cystic periventricular leukomalacia or intraparenchymal hemorrhage have a 30-fold increased risk to have this, to present cerebral palsy. As well, not necessarily cerebral palsy, but motor disability at 30 months old is highly predictive. It can tell us how motor performance will be later. However, 38% of the children that at 30 months old are diagnosed with no disability or other disabilities are found to have moderate to severe or severe disability when they are reassessed at 6 years of age. And well, the biggest problem of all these sensory motor neurophysiological problems are that sensory impairments are often associated with later cognitive and social impairments, meaning that, for example, problems later like HDAD or cognitive problems or mood disorders have been related or may be related to these sensory and motor impairments found earlier in life. And there are two important things to consider when we talk about the damage produced by brain injury. On the one hand, as time advances, lesions start to install with different mechanisms. There's a primary cell death, but after hypoxia ischemia, other factors like these injurious factors of cell swelling, inflammation, all these associated with glial cells, and these pre-apoptotic cascades and apoptosis take longer time to produce a secondary cell death. Finally, as this inflammation persists and progresses, there's a tertiary cell death. Then there is arrest in this oligodendrocyte population, which is very important, as we know, to form the myelin that will allow long distance synapses and communication. And then when there's this impaired myelination, well, this cystic injury is also formed. And then finally, there's an impaired connectivity, white matter atrophy, and ventriculomegaly, but which progresses in the order of months or even years. So at the beginning, when this lesion, if it is perinatal or around labor, this lesion it's not completely expressed, and its expression increases over time. But at the same time, when the infant is recently born, when it's young, very young, neuronal plasticity it's in its maximum level, and it starts decreasing rapidly. So this time, where we have high neural plasticity and the injury expression is still minimal, it's a great neurohabilitation window. It allows us to intervene, and then it's a great opportunity. Katona's neurohabilitation method uses this. One important thing is then early therapy is more likely. Data say that early therapy is more likely to be effective than therapy after infancy. Katona's neurohabilitation method is a diagnostic and therapeutic tool. It is based on elementary neuromotor patterns, which are chains of processes in which neck, trunk, and extremities carry out complex and continuous movements with two main objectives. First, verticalization of the body, and the second and very important function of movement is locomotion. And these elementary neuromotor patterns are controlled by developing subcortical structures, and they are activated by head and body positions that trigger activation of vestibular nuclei and the projections to the spinal cord, reticular formation, thalamus, cerebellum, and basal ganglia. So proprioception is also a very important part of this activation of elementary neuromotor patterns, which allow a baby first to hold the neck, next to hold its trunk when sitting, then to crawl, and finally to walk. So vestibular stimulation produced by these movements activates the cervical, axial, and appendicular muscles and their proprioceptors, and the general categories of these enabling maneuvers are trunk lifting, sitting in the air, horizontal drag, assisted crawling, and elementary gait. That is the final goal. And well, in our sample, we particularly found at these three ages. I want to show you these samples to show you how even at the beginning, when they are 2 to 3 months old, it's possible to observe that there's a better development in term-born infants. And then as time goes by, we can see that the differentiation and maturation of brain improves, but many of the volumes, for example, in the case of ventricular, in lateral ventricles, the size it's even increased in some of them, not in all of them, but also we see that the size of corpus callosum and in general the size of the brain, it's still affected. So let's remember, and it's a very important thing to remember, that the more an infant is born before time, the more affected the brain is, not only in the short term, but also in the long term. And of course, it also depends on the original lesion that this infant experienced. In the case of our sample first, the corpus callosum increased in volume in all cases at all times during growth, but in the case of lateral ventricle volumes, we had different results. In 68%, that is most of them, lateral ventricles volume increased. In 16% it was unchanged, and in the other 16% it was decreased. The neurodevelopmental outcomes, in the case of the MDI, or Mental Development Index, 73 were normal and 9% had an accelerated Mental Development Index, which makes up for a total of 82% with a good or adequate mental development, but 18% were severely impaired. In the case of Psychomotor Development Index, 73% had normal and 4% accelerated, with a total of 77% infants with an adequate, or well, in this case kids with an adequate psychomotor development, but 23 which had severely impaired psychomotor development. So as a conclusion, Katona's neurohabilitation method is useful to prevent long-term neurological sequels in infants with risk factors for brain injury, considering all the accumulation of risk factors that these infants had. Well, this more than 80% with an adequate mental development and 77% with an adequate psychomotor development are great news. Also, there was an increase in the volume of the corpus callosum, which may be the structural basis of normal development outcomes in children treated with Katona's neurohabilitation method. And this is something to further remember. These are some reference, and I just want to thank, first of all, the participants in this study, Dr. Elia Harmony, who directs the Neurodevelopment Research Unit and this project. Also to our collaborators, Dr. Manuel Hinojosa Rodriguez, who helped on the clinical assessment of the images, Cristina Carrillo Prado, who is in charge of this administration of Katona's neurohabilitation method, Claudia Gutierrez, who is in charge of the psychological assessment, and Paulina Alvarez, Hector Belmont, Oliver De Leo, Lourdes Cubero, Jorge Garcia, and Laura Estrada for their collaboration. Also received financing from PAPIT, that is from UNAM, the university, National Autonomous University. And well, thank you for your attention. Good